Good afternoon, and thanks for joining this event today. I hope you can all hear me well. My name is Valeria Fagone, and I'm a Senior Director at FTI Consulting. I'm very pleased to moderate today's event from the Transforming Breast Cancer Together initiative on different access and different outcomes, tackling inequalities in breast cancer care across the EU today. So welcome, everybody. The Transforming Breast Cancer Together initiative is a collaborative initiative to improve breast cancer prevention, diagnosis, and care. And all the different activities and events that the initiative has organized over the years have been driven by the goal to elevate breast cancer as health policy priority and to improve prevention, diagnosis, and care across Europe. This will be the key topic of today's discussion. Today, our policy debate focuses on inequalities in breast cancer care, which regrettably still exist, not only across member states in the EU, but also within countries and within regions, thereby shaping the realities of European breast cancer patients. We've seen last week the OECD published the Health at a Glance report, which highlighted that although the quality of outcomes of breast cancer care has generally been improving in recent years, the pandemic may have actually had a negative impact on breast cancer outcomes. TBCT, the Transforming Breast Cancer Together initiative, highlights the importance of addressing these evident disparities in the cancer journeys of European citizens and dedicates this event to identify these inequalities, to underline the consequences and to debate concrete solutions to harmonize prevention, diagnosis, and treatment, and to improve the quality of life of patients in the EU. So to achieve this, the initiative is bringing together different perspectives of patients, of physicians, of policymakers. And today we have a great panel of distinguished experts and speakers composed as follows. We are very pleased to have Luciana Neamtiu, who is Project Officer at the Healthcare Quality Team and Cancer Information Team at the European Commission Joint Research Center. Welcome, Luciana. Dr. Fatima Cardoso, who's Director of the Breast Unit at the Champalimaud Clinical Center in Portugal, and is also President of the ABC Global Alliance and a member of TBCT. We are pleased to have MEP Pietro Fiocchi, who's a member of the Special Committee on Cancer and a member of the Environment, Health and Safety Committee in the Parliament, as well as Marzia Zambon, who's Executive Director of Europa Donna, a key member of the Transforming Breast Cancer Initiative and representing the patient's voice. So thank you very much all for being with us today. The TBCT group would like to take this opportunity to remind you all that the Breast Cancer Awareness Month has just come to a close, and we should all continue making a difference beyond the month of awareness to improve the realities of patients and keeping to raise awareness about the disease, not just in October, but every month of the year. Before I give the floor to MEP Frances Fitzgerald, who is the chair of the initiative and will provide a welcome and opening speech, I would like to just take a moment to take you a few housekeeping rules for the discussion today. And first of all, as this is a webinar concept and format for the debate, all participants, as you can see, will be off camera and on mute. We're very interested in hearing your views at the end of the event. So our panelists will be really happy to answer your questions. So please do send them in written in the Q&A box that you can see at the bottom of the screen, and we will pick them and ask the panelists to respond to your comments and questions. So please write them in a short format and indicate your name and organization if possible. Please also note that you see a red dot flashing on the screen. This is because we're recording this event. So with that, we can proceed with this very interesting discussion, and it is my great pleasure to hand over now to MEP Fitzgerald for her opening remarks. Thank you very much.
Good morning, everybody, and I hope you can hear and see me okay. I take it you can, yes. I'm delighted to be here with you this morning as chair of this initiative, Transforming Breast Cancer Together. This is a very important debate and discussion about different access, different outcomes, and tackling inequalities across the EU. We have serious inequalities across the EU, and of course, the COVID situation has exaggerated all of those, and now again with rates increasing, an issue we must look at once again. The month of November is our anniversary. We started 4 years ago this month, and we want to keep breast cancer issues high on the agenda across Europe and of course nationally as well, because we want to have improved outcomes for patients and their families right across the EU. Last month we had of course Breast Cancer Awareness Month, and we know what the reality is like for those living with breast cancer. We have many experts on our panel today to discuss this. Obviously, awareness doesn't stop at the end of October. It is ongoing. The realities of cancer patients in Europe differ substantially, and we have a lot of research to prove that to us now. There's variability in cancer diagnosis, there's variability in treatment, there's variability in outcomes. Maybe national cancer control plans are not being implemented, for example. So we have to be very vigilant. Monitoring, setting targets and monitoring those is really important. It's very disturbing when you look at the current data. So you see, for example, that Eurocare4, a study monitoring cancer survival in the EU, showed that delivery of standard of care surgery for breast cancer patients, it varies incredibly from 98% in France to 9% in Estonia. And the ECPC, our European coalition, shows, for example, in that report, that huge disparity. And access to medicines, of course, varies enormously. And with the huge innovation in medicines, including in cancer treatment, we have to be very alert to access issues. And we need more European initiatives to make sure that innovative medicines are reaching cancer patients as we make progress in the research area. For example, recently we also saw that Belgium has one of the highest rates of breast cancer, where again, 188 women in 100,000 are diagnosed with breast cancer. It's an alarming number, but the recovery rate is fairly high in Brussels, ranging from 85 to 90% when a tumor has been identified at an early stage. And of course, that's the key. And that's what we worry about with COVID, the tumor being identified at an early stage, how we can ensure that that's the reality for women right across Europe. And I want to say the problem is not just across Europe, it's within countries as well. We all know that you have urban and rural divides in our member states, and that's a very serious issue as well. We try to have our centres of excellence that everybody can have access to, but that's not always available in all our member states. So we know that early detection is absolutely crucial. Delays can be absolutely fatal. There is encouraging evidence from high-income countries which indicates that screening with mammography can reduce breast cancer mortality significantly, as long as we have the required capacity, funding and infrastructure to do it properly. A quick word about COVID-19. We all see the increasing rates at the moment. We all know that not enough women, and men indeed, but women with symptoms of breast cancer attended their services. And we have disturbing evidence from the European cancer organizations that 1 million people have had their cancer diagnosis delayed. And I know that some of our experts, Dr. Fatima, for example, has spoken about this on previous sessions. So there's an urgent need to address this fragmented approach that I've described. We believe national cancer plans must be centered around patients and their needs and built on adequate and up-to-date information, and to take account of how cancer affects not just patients, but of course their families, their carers, their work, their employment. This is very important. We have to look at the realities of European citizens with breast cancer and debunk common misconceptions. And this webinar is all about doing that. There are inequalities. We must discuss them. We must address them. And we must be very conscious of COVID and the impact that it can have. Our hospitals in some countries are getting overwhelmed. Our emergency departments are getting overwhelmed. How can we make sure in this context that cancer patients with symptoms are seen and seen urgently? And then again, how are we going to tackle the inequalities? This is what our organization, Transforming Breast Cancer Together, cares about and wants to deal with. It's a good time in Europe with the cancer plan and more committees here in the European Parliament to address this. But thank you again, everyone, for facilitating this and being part of it. And welcome to all our participants. Thank you.
Thank you very much, Mrs. Fitzgerald, for your encouragement and for pointing out these key elements that indeed we'll try to now dig in the panel discussion as well. So thanks a lot for continuing to put your efforts into the initiative and driving awareness on this point. Thanks. Now, I would like to then give the floor now to Ms. Luciana Neamtiu from the Joint Research Center to really look at what is the context of these inequalities in breast cancer, and maybe look a little bit at some data and figures that indeed the JRC has been pulling together. So Ms. Neamtiu, thank you very much for taking us through that.
Good afternoon. Thank you very much for the opportunity to present today. The Joint Research Center is the European Commission Science and Knowledge Service, which employs scientists to carry out research in order to provide independent scientific advice and support to EU policies. And first slide, please. Some data on female breast cancer burden in EU 27 based on the European Cancer Information System 2020 estimates. As you can see, breast cancer is estimated to be the most diagnosed tumor among all cancer types and the first cause of cancer deaths among women in 2020. And there are differences between EU countries regarding both incidence on the left side of the slide and mortality on the right side. It is estimated that breast cancer accounts for 13% of all new cancer cases diagnosed in EU 27 in 2020, and this makes it the most frequently occurring cancer. And it is estimated that it accounts for 28.7% of all new cancers in women. Incidence trends in EU 27 are mainly increasing, and multiple factors explain these changes, including reproductive factors, increasing obesity and physical inactivity, as well as increasing screening intensity. Next slide, please. The 5-year survival on breast cancer patients diagnosed in 20 to 27 is highest in Northern and Western Europe and lowest in Eastern Europe. National differences can be in part explained by the varying levels of healthcare expenditure and resulting quality of diagnosis and treatment. Next slide, please. 2 surveys were prepared and distributed by the GRC to cancer registries affiliated to the European Network of Cancer Registries, one in 2020, and the second one year later, from July to October 2021. And you see on the screen the situation regarding breast cancer screening. In the majority of the regions covered by the cancer registries responding to both surveys, breast cancer screening was stopped or slowed down. Also, non-urgent diagnostic visits for cancer were generally reported as disrupted, especially during the first wave of the pandemic. And the most disrupted type of treatment was surgery. Next slide, please. What is doing the Commission to tackle all these issues? The European Commission Initiative on Breast Cancer is a patient-centered initiative, and it was launched with the aim to improve the quality of breast cancer screening, diagnosis, and care, and to contribute reducing inequalities in accessing breast cancer services across Europe. Improving the quality means providing minimum essential requirements which are implementable throughout all the member states. The objectives of the ECIBC are achieved through the development of European cancer guidelines on screening and diagnosis and an associated quality assurance scheme for breast cancer services covering the entire pathway of breast cancer care, providing quality indicators and requirements based on the best available evidence and guidelines. You can have more information using the QR code on the slide. Thank you.
Thank you very much, Ms. Neamtiu. This is striking data and a concerning picture that you painted through this information. So we'll certainly comment on it as we go through the other interventions and the panel debate. So thank you very much for that. Following that, Dr. Cardoso, could you kindly give us your view from the clinical standpoint about what are the issues that these inequalities are posing from clearly a clinical standpoint, a health system standpoint?
Thank you very much. Thank you for the invitation to be here. And I would like to start by emphasizing two things that were said already by Mrs. Fitzgerald and Mrs. Neamtiu, is that inequalities are not just between European countries, but within European countries, within regions, but also within just people. And for us, in the clinical practice, our therapeutic decision should be based on science and on patient preferences, but should not be, as they are now, more and more based on what the patient in front of us can afford, because this poses a huge burden on patients, on their families, but also on the healthcare professionals, since this is not the right way to practice oncology. In inequalities, I would like to highlight that they are not just linked to expensive medicines. I believe that we talk a lot about expensive medicines because it is probably one of the easiest points to see and perhaps to tackle. But unequal access also relates to other issues that are crucial for adequate breast cancer care, such as access to multidisciplinary specialized teams, preferably within breast centers or breast units, which is a very long fight for many of us in Europe and is not yet implemented equally in all countries. Inequalities are also linked to high quality pathology, which is crucial for a good diagnosis, a good determination of the subtype of breast cancer. And without a good pathology, we cannot take proper therapeutic decisions. So access to surgery and radiotherapy is also very unequal. And it's also very unequal access to genetic testing. And genetic testing has now not just implications in terms of determining hereditary breast cancer, but also therapeutic implications on both local and systemic therapy. One of the issues that is mostly impacting inequalities directly for each individual is the reimbursement rules that exist in different European countries and different health systems. So they have not evolved with the evolution of science, and they are not patient-friendly. They do not favor shorter treatments of radiotherapy. They do not favor access to oral treatments instead of IV treatments, and we could dissect this a little bit later. Also, would like to emphasize that other types of inequality exist. So there are inequalities based on age. Elderly patients are often undertreated, while younger patients are often overtreated. And this is something that it is not also correct. Also based on gender, males can have breast cancer as well, and this is often forgotten and not provided the adequate access to the care and the needed care. And finally, also according to stage of disease, metastatic breast cancer or advanced breast cancer, because it is incurable, in many countries, these patients have difficulty in accessing innovative treatments because they are expensive and because there is this feeling that since it is incurable, it's not worthwhile to invest in these patients. So there are many types of inequalities, all of them very unfair, and all of them very much linked to outcomes. And I'll finalize by saying there are many studies that link investment in health and oncology in particular, as well as accessibility to outcomes in terms of mortality and quality of life. Thank you.
Thank you very much, Dr. Cardoso. We really looked at the different aspects of inequalities, of what they mean to patients. Indeed, we'll go certainly back on that, and I'm sure this will raise questions. MEP Fiocchi, we'd like to also ask your views, and it would be great if you could share with us how do you see improvements in breast cancer in Europe, but also what are the issues related to cross-border care, and your views concerning that. Thank you very much.
Thank you very much. First of all, the data that was just presented was extremely impressive. As I'm not a doctor, I'm not a medical researcher, but I'm an engineer with a passion for numbers. I think we do have enough data to do the correct analysis and to start using all across Europe the best practice cases, which have shown to give us some extremely interesting results. If you look at, for example, at the percentage of death by cancer by nation, you see Italy, which surprisingly is minus 13% on men and minus 10% on women with respect to the average European numbers. And the one should analyze the situation and try to understand why is that? Is it that the Italians have a better diet, they're less obese, we have a better health system, we have a better screening system, and so on and so on and so on, and trying to find the reason for this success and apply it to all the rest of Europe. Now, for me, another set of data which was extremely interesting is the difference, but you already mentioned this, in type of screening and early diagnosis of cancer in general and breast cancer in particular. When you see that you have regions that have maybe only 6% of early diagnosis on risk factors, and some other region that you have 90%, it really hurts, because you imagine a Europe which is all the same all across, but it's not. And this, I think, is one of the key points in which the European Parliament and the Commission needs to be working very strong. Last set of data, then I come to the BECA results. Extremely interesting for me and in some way depressing, the fact that in Italy alone, last year there were 2.5 million screening less than a year before, which is really dramatic. And especially on breast cancer, minus 26% with respect to the year before. Obviously, COVID had a horrible impact on the data and on the healthcare of the interested people. Now, when you come to BECA, in my opinion, it is a very good, a very strong document. It is very good on regarding prevention, screening, and pushing for good behavior. So the prevention of the causes of cancer, obviously with a lot of focus on smoking and alcohol consumption, but also the diet, the obesity, the problem of course, excessive use of red meat in some region of Europe, and so on and so on and so on. There are some areas in which, in my opinion, we need to get better, and we are working on this. But for example, everything that is concerning what happens after the hospital therapies when you go home, which in a lot of areas of Europe, the patient is basically abandoned to himself. There's no any kind of support regarding nutrition, regarding rehabilitation, regarding therapies, regarding whatever, have also psychological support in a lot of cases. And so you're abandoned at home when it has been proven in some region of Europe where a comprehensive care that starts even before going to the hospital at home and continues after the therapies or the intervention has been done in the hospital give some results which are much better than the rest of Europe. There are some other points, and you already touched some of these points. For example, I would like to see in the BECA document a much stronger push regarding the new technologies. There will be some money available for R&D on the new technology and for the investment, funds for the investment in the new technology. So this is positive. But on the other hand, and here we come to a very weak point in Europe, it's extremely difficult to push for a comprehensive database on oncological care, which in my opinion will be extremely important also to help identify to the health community, the excellency center where they have a much better success rate in curing certain type of oncological cases, and they're much better in certain type of both diagnosis and screening techniques, but also cure. And I mentioned, the nanomedicines and radioligands and so on. Unluckily, there is an obstacle for this database, comprehensive European database, which is given by the privacy. I know that privacy is important, but on the other hand, unluckily in this case, is a big obstacle. And this is really a pity, because my personal opinion is that we do not have much privacy anymore, but to use the excuse of privacy not to have an extremely powerful instrument to cure people, it would be really a pity. But this is a big political discussion. The last point in which I think BECA is still a little weak and we need to do more is the free circulation of patients in Europe. Not only inside the nations, which is in some cases difficult, and you already mentioned this, but also cross borders. And unluckily, there is a lot of problems. Some of them are fiscal problems because the type of therapies or screening or whatever cure has a different cost in the different nations. So there is a problem also of reimbursing this money across the borders. And plus, there is a lot of bureaucracy, let's face it. If I want to go cure myself in Hamburg or whatever, and it gets really extremely difficult. Plus, of course, going back to the database, in a lot of cases, there's not the correct information on where to go and how. So, but working on this. As we speak, there is a technical meeting in BECA. We will have soon a more political meeting regarding this, but I think overall the people that are working on the BECA report are really good people. They're really open to dialogue. They are really prepared also from a technical point of view, because I mean, Trilele Noir is a doctor, but also Peter Lees of the PPA and so on. There is a lot of discussion and a lot of really push to come up with the best possible document so that we can really bring home some good results at European level and potentially reduce the overall cancer death rate by 40% if we do everything right. So this is it. I mean, I know it's a very complex and big topic, so I will stop at this, and if you have questions, I'm here to answer. Thank you.
Thank you very much, MEP Fiocchi. We indeed have a lot of trust in the potential that the cancer plan, the BECA report can have, of course, and I will now ask Marzia Zambon, who represents the voice of patients in breast cancer in Europe, at Europa Donna, to maybe tell us a little bit more about the views of the patients on what the solutions can be, what indeed the key advocacy points are from the patient community. Thank you very much, Marzia.
Okay, thank you. Thank you very much for having me here. And I would start by echoing what MEP Fitzgerald and Fatima basically already said. Inequalities exist, and they are both between and within countries. They reflect language barriers, disability, socioeconomic issues, geographical and population density issues, gender, age, and disease stage, as Fatima pointed out. There are so many different factors which come together to create disparity. And unfortunately, it is a proven fact that inequalities are directly linked with large disparities in the chance of surviving the disease. So this is quite important for European patients to know and to fight for. Much progress has been made in these years. We are a very old organization. We have been advocating for over 25 years. And as the European Breast Cancer Coalition, and we have seen and contributed to great results. Today, almost all of the 27 EU countries have a population-based screening program for breast cancer. And as Luciana pointed out, European guidelines set common uniform quality standards for breast cancer care. And it goes from screening and early diagnosis to treatment and care. But of course, some countries are still struggling. For many European breast cancer patients, access to specialist cancer centers, specialist breast units, we call, with a multidisciplinary team, a truly functioning multidisciplinary team with all the professionals, such as the pathologist, and a specialized surgeon, and possibly a breast nurse, is still a very far away dream. A main advocacy point we are making now is to try, in order to try and fight inequalities, is to insist on national legislations implementing specialized breast units with multidisciplinary teams, and most importantly, ensuring that they're defining their criteria be objective and uniform throughout all European states, in the sense that national and regional criteria are actually in compliance with the standards at a European level as set by the ECIBC guidelines. A second point I would like to make is that for the first time in Europe, the European Commission and the Parliament with BECA, they have put together a unique project with a comprehensive spotlight on cancer, and clearly defined pillars, clear action pathway, a time frame, and that the necessary funds were allocated through the EU for Health program. We are also in a unique moment with COVID having shown policymakers, EU member states, and all stakeholders that it is actually better to move forward together, to collaborate, to engage, and to accept central coordination. It is possible to reach an unimaginable result in a very short time, and this is what COVID has taught us. I am truly confident that in the next 10 years, we will see great progress in the fight against cancer. But in the end, what really truly counts is implementation and accountability. So effective action is to be taken at a European level, overcoming the barriers and finding practical solutions, but mainly and utmostly, the success of a cancer plan will depend on its actual implementation by member states. So following the European example, each country should have a clear and transparent national cancer plan. And each country should have clear timing and funding for the implementation of specialized breast cancer centers with multidisciplinary teams. But most importantly, national cancer plans should set objective monitoring and accreditation procedures in order to make sure that these cancer centers are in line with equal and uniform criteria and in line with the European levels. Last point, I'd just like to pick up on what MEP Fiocchi said about screening and COVID and the effect that COVID had on screening. We are now moving as Europa Donna in our 47 member states to make sure that we check that national programs are implemented in order to make sure that the backlog of the missed screening, especially during the first waves, and then thereafter when women were actually scared of accessing medical facilities. So a lot of screening was skipped. So both health facilities should make sure that those women are called back, because if not, 2 years is a long time. And we will find a lot of later stage breast cancer situations there. And also we are starting campaigns with women to create awareness to that they themselves call the health facilities and make sure actively that and seek to have their screening done regularly. Thank you so much.
Thank you very much, Ms. Zambon, for these very clear calls to action indeed. And thank you all for providing your views and this really starking information and data on the current situation. What I'd like to do is really a very quick round of questions to you. And meanwhile, I ask the participants who do have a question to write it in the Q&A box with your name and organization, so we can pick them up during the debate. Meanwhile, Dr. Cardoso, you've talked to us indeed about the various aspects of inequality and the importance of making sure that the patients have not to face a question of being able to afford the treatment and that have availability of screening and care. From your point of view, what can be the solutions to some of the barriers or the inequalities that you mentioned? Very briefly, your top priorities.
Thank you. So I think there are some solutions already out there that could be used by regulators all over the European countries. For example, for expensive medicines, both the European and the American Society of Medical Oncology have developed objective tools to prioritize or to give a value to the benefit, to the clinical benefit of each new treatment. And that scale allows us to prioritize what is really meaningful in terms of advances and what is just so-so. And so if you have a priority made based on science, then you can just, according to what you have in your country, decide up until where can you go in providing availability. What is not correct is to provide availability of expensive drugs that provide minimum benefit and then not have enough money for those who provide a substantial benefit. So the tools are out there, and people just can start using them. For example, in Germany, this is already done. It's funny that it's done in a wealthy country and not in a not so wealthy country. Then other tools that exist and can be used already. So I think that through the work of Europa Donna and other patient representatives, we are seeing more and more the engagement of the civil society and the patient representatives. But I think we are still miles away from, for example, the United States and the United Kingdom. And I think it is time that the civil society gets more involved and gets more into action against these inequalities. Because if we are just speaking among ourselves, we will never get very far, right? And we need not just the Parliament and the European Commission, the European Parliament, to listen to us. We need our own parliaments in the individual countries to listen to us. And they will listen if it is the civil society, if movement comes from the civil society. So I think there's enough experience in other countries that we can take on and start implementing in our own countries. Lastly, what I mentioned about the reimbursement rules. We have issued, and Europa Donna has participated also at the European Breast Cancer Conference, a manifesto giving concrete examples of what can and should be changed and is not implemented in Europe. And there are minor things, they seem minor things, but they are not implemented. They then could save money, not expend more money, but actually save money, as well as improve the quality of care. A very simple example. Nowadays, for radiotherapy of early breast cancer, we should use 15 sessions. 15 sessions is has the same efficacy, same quality of life. And of course, as you can think, if instead of the traditional 25, we do 15, we save waiting lists. We can treat 2 patients for the time of 1. So why is this not implemented everywhere? Because in some countries, radiotherapy is paid per session. And so even in public hospitals, this is not implemented. And I'm trying to understand who is benefiting from this, and I cannot find. Nobody's benefiting. Certainly not the patient, certainly not the states, certainly not the health professionals and so on. So why not change that? The other thing is, in many countries, you get only reimbursed if you use the day hospital. But the new innovative treatments are very often oral treatments. And if you cannot use them because you must go to the day hospital, again, nobody's winning anything with this. So very simple things that would mean a lot and would save money to governments as well. I hope that we can implement this, and as well as implementing the very long-standing fight for breast units all over the European countries.
Thank you very much, Dr. Cardoso. These are very concrete suggestions indeed. Ms. Neamtiu, you've given us an initial description of the role of and the mission of the European Commission initiative on breast cancer. What is next? What are you now working on that front?
So up to now, recommendations on screening, diagnosis, communication, staging and planning the treatment, as well as on training for healthcare professionals were released. Updates of these recommendations as soon as new evidence appears are also done. You can check everything is publicly available on the website and immediately published. There are versions tailored for women and patients. Then regarding the quality assurance scheme, there is a diversity of organizational settings for breast cancer care between countries and regions. And this was highlighted in an earlier report done by the Commission. So for these reasons, the scheme has been developed as a modular scheme, enabling different legal entities or geographically separated services to participate for the range of breast cancer services they provide. What is important to have a coordination in the delivery and continuity of care to individuals. So someone who will have a positive result in screening should be taken in a service, diagnosed and then treated. Up to now, and the scheme is completed, 86 requirements for the entire care pathway were developed. Manuals have been developed for each main actor involved in the scheme's implementation process. The manuals are freely available on the website. All the requirements are listed and described in the manual for breast cancer services. And then there is a scheme owner manual which set out how the scheme is organized, managed, and maintained, and how the certification process is carried out. There are some tools to help the services to determine their preparedness to comply with the requirements, and to support to compute indicators in a standardized manners. Training and training materials are also available for auditors and auditees, and each individual component will be tested in real settings before the full rollout of the scheme. Now we are in the phase of testing the feasibility of the developed requirements in real settings, and this exercise will consist in assessing the compliance of a number of breast cancer services with the developed requirements via self-assessment tool, as well as a quality indicators calculator. We have 15 centers from 10 European countries participating in this exercise. And we are also in a preparatory phase of the pilot run together with the European accreditation. In this step, the certification part will be tested. So these are the updates. Thank you.
Thank you very much, Ms. Neamtiu. It's very certainly very promising, and will certainly, I'm sure the Transforming Breast Cancer Together initiative will look at the progress that is being made within the initiative, the Commission. Mr. Fiocchi, I'd like to pick up maybe a question that has come through the Q&A box from one of the participants, Ellen Verschoor, as the question is actually about the role of the EU in providing funding to member states for implementing screening programs and setting up special breast cancer units. Do you think indeed the EU has a role in this respect? Could you comment from your perspective of a representative of the European Parliament, please?
No, for sure the EU has a role. I can talk specifically about the Italian case in which the resilience plan has allocated some important funds, and part of these funds are allocated to the health sector. Now, the problem comes that the push from Europe is in the right direction, but then we need to see how the single member state will utilize this money. So that's the key point, because I've seen, again, talking about the Italian case in which the regions have a lot of power in deciding the different health strategies. I'm witnessing some regions which are pushing a lot to use these funds, these European funds, to not only kill the delay due to COVID, but actually to increase the percentage of screening on risk factors all across all the oncology cases. But some other regions are going in a different direction. So it's the EU started well. We need to see what the member states and the regions will do with that money. So this is a very good start. Of course, it helps to put a lot of mediatic pressure and political pressure on the member states to go in the right direction. And we will work in that.
Thank you very much. Ms. Zambon, maybe you've really told us about what are the key asks or what the patients are looking to see happening, including within the context of the cancer plan and its objectives. If you had to tell us what are your top, maybe 2-3 asks to policymakers, what would you prioritize then? And this is, we know the Parliament is indeed finalizing its report on the cancer plan. What would you say?
Okay, we have so many, but let's, at this time and moment with the COVID effect, let's say, I think we should really make sure that EU policymakers strongly recommend that national health services implement effective telemedicine, coordination with the GPs and social services, taking the cancer outside the hospitals. I've heard this phrase said many, many times. Of course, there are barriers, and Fatima explained one of those during our Pan-European conference last month. For instance, a telemedicine visit, how do you bill it? How do you pay for it? A lot of national health systems have not started dealing with that. So I think we mainly need a plan focusing on true effectiveness in solving practical problems in a simple, direct, and fast way. One further thing, and this is also a lesson learned from COVID, is that work flexibility is possible. This was said in MEP Fitzgerald's introduction. I've heard it said many, many times by Fatima as well. A patient is a person outside of the hospital with a life, a family, practical engagements to deal with, financial issues to face, especially with a disease. When you're facing a disease, the caregiver of a patient also has to deal with a lot, having to look after a loved one, and it's a personal, psychological, social, and economical burden for all. So it is very important for EU policymakers to strongly state and recommend for national legislation to implement legislation, laws, in order to allow flexibility on the job for people living with breast cancer, both early and advanced stage. Or also with the long-term effects after diagnosis and treatment. This should be something that must be central for at an international and national level now all over Europe. Thank you.
Thank you very much for this important call. I don't see more questions in the Q&A box. I'll just take maybe a few seconds to see if anybody else would like to place a question for our panelists. I'm also conscious that we have the last few minutes in the hour we had planned. If someone would like to come in, please do send a quick message in the Q&A box.
I have a question for the other panelists. Please,
Mr. Fiocchi, go ahead.
You know much better than me the situation in other single member states. In Italy, we have a situation in which a certain type of screening or exams, you have a 2 years waiting list, which of course you can bypass if you go private and you pay with your own money. which is causing us, in my opinion, a major social problem, because if you're poor, especially if you live in a rural world and you're not well informed, you don't get organized, the risk is that you don't get screened. Is this the case all across Europe?
Unfortunately, yes. So what we call the underserved or hard to reach populations, this is a major issue all over Europe. The ones that you mentioned, living in more distant or rural areas, the ones with lower socioeconomic status, the ones with lower educational levels. So all those are usually also the ones that are poorer. And so everything gets together in a combination of factors that leads to worse access to care, starting with worse access to prevention and screening. So bigger cancers, more advanced cancers are diagnosed, and also problems in treating those. So it's like a snowball, and everything is going to be worse. So for example, for these type of populations, together with many of our members, the Advanced Breast Cancer Global Alliance has a toolkit with different projects that have been implemented, not just in Europe, all over the world, exactly for these type of populations. And it's there, freely available, where people can go and get inspired, or even use the resources already there on how to raise awareness, lead to earlier diagnosis, because it makes a huge difference. It makes a huge difference in terms of survival, but it also makes a huge difference financially. It's about 10 times more expensive to treat metastatic cancer than early cancer. And so if we diagnose earlier, we also save money for all of us, society. So it's a win-win situation for the patient and for the society.
Thank you very much, Dr. Cardoso, and thanks, Mr. Fiocchi, for raising this important question. Unless there are other questions from the participants, I'd like to maybe sum up some of the key points that you've shared with us today, and that I think really have enlightened the debate on inequalities in breast cancer across Europe. First of all, Mrs. Fitzgerald raised our attention to the fact that inequalities are still extremely big, and not just across member states, but even within the same countries or regions, and that there is research indeed that is proving these. She also highlighted how early detection is key, and we know what a difference it can make for patients. She mentioned the 1 million people. I was very astonished by this figure, had delayed diagnosis, which is indeed, as we've discussed, a very important consequences, and that indeed there is a need at a European level to address these fragmented approaches that we're seeing across member states. Some of you have highlighted the impact that COVID has had. Ms. Neamtiu from the JRC indeed looked particularly at how screening was affected by that. Mr. Fiocchi, you also just took on the example of Italy and the delays that the pandemic has created on access to screening, particularly maybe for some populations. Dr. Cardoso, you just referred to that, and maybe more remote or hard to reach populations, as you just said. These differences are clearly starting from many points of view. They concern, of course, not only care, but they concern indeed screening, a diagnosis. They concern even prevention, as access maybe to policies, or the implementation of policies on risk factors, maybe, and the monitoring on these things is not the same across Europe, and Europe doesn't seem to be the same across the board, as some of you have mentioned. the role of the cancer plan clearly is very, very important. There are high expectations. There are maybe a number of points which need to be stressed through the Parliament report, through the debates that are taking place, and civil society clearly has indeed a role to play on that. We've seen indeed the inputs that many of you have suggested and shared today, the voice of the patients, indeed, as Ms. Zambon has also highlighted, the need for not just having a good cancer plan, but making sure that then implementation and accountability are there, and that the plans are really activated at a national level and executed fast as well. So I think that some other solutions or actually interventions were mentioned, including the creation of maybe a comprehensive database that can provide indeed for exchange of data, information about access to a specialized center, and indeed appropriate investments in creating those multidisciplinary approach, the breast cancer units. I think were all important inputs that were given today. We want to make sure that all these points, of course, are kept in mind by policymakers. Certainly, Transforming Breast Cancer Initiative will bring them forward in its advocacy to ensure that they don't remain just a dream, as some of you have said, but they become a reality across Europe. So thank you very much for this very interesting discussion today, for sharing your inputs. Thanks to the participants and the questions. I would just like to make a last point. We're very happy to announce that later today, the Transforming Breast Cancer Together initiative will be officially launching its website. It will have an online presence. Please do go and visit www.tbct.eu. This will be really a repository and a place to go finding information about the initiative and its asks and policy initiatives. So we hope to see you numerous visiting the site soon. So thanks again to everybody, and a good continuation of your day. Thank you very much.
Thank you. Bye.
Thank you.
Goodbye.
Bye.